Hello, and welcome to the Clinical Liver Diseases video series. Clinical Liver Diseases is an official digital learning publication of the AASLD. I'm Mark Sonderup. I'm a hepatologist based at the University of Cape Town in Cape Town, South Africa, and the author of a paper that is currently being published looking at the burden of hepatitis B in Africa. The issues of hepatitis B in Africa are substantive. If we look at the global burden of hepatitis B, then a mere 17 countries make up almost 3/4 of the global burden of hepatitis B, of which 9 of these countries, in fact, reside in Africa. That puts into context the burden of hepatitis B on our continent. We have almost 65 million people chronically infected, however, enormous challenges. We have the largest number of children under the age of 5 chronically infected globally, and the number of annualized infections continue to be alarming at almost 1 million new infections per year. There have been substantive moves to try and address the endemic nature of the virus on the continent. And now over 50% of countries in Africa, in fact, have global national elimination strategies in terms of trying to address the burden of viral hepatitis in Africa. The problem is we have a long way to go in the sense that we have only 14 countries who have introduced the hepatitis B birth dose vaccination. And we have projections putting that by 2030, we will not have achieved the important and crucial milestone of less than 0.1% of children under the age of 5 being chronically hepatitis B virus infected. So the challenges are enormous, but we have a number of potential strategies that in fact we could use to address the challenges at hand. In conclusion, what we have tried to demonstrate in our article is that there are a number of issues that can be tackled to try and address the burden of hepatitis B. Firstly, and probably most importantly, is a continental prioritization of hepatitis B as a public health burden. We also have the need to rapidly upscale the expanded access to testing and treating of people for hepatitis B. We need rapid linkage to care. And importantly, we need to leverage on simple interventions that can assess the nature of liver disease and strategize and thus stratify patients in terms of risk for either cirrhosis or hepatocellular carcinoma, the 2 major disease burdens associated with hepatitis B. If we can do these simple interventions, expand testing and treating, introduce effective strategies to limit mother-to-child transmission, such as birth dose vaccination, as well as mothers accessing tenofovir during pregnancy, and the expanded access of patients to screening for hepatocellular carcinoma, we can in fact achieve a true hepatitis B-free generation. So on behalf of all of us at the Clinical Liver Diseases team, I hope you found the short commentary of mine useful. For more information about the topic we've written on, namely the burden of hepatitis B in Africa, please visit us at www.cldlearning.com. And thank you very much for watching.